right, good morning, everybody. Thanks for joining us. As some of you might know, I'm Tony from Mercy Perrysburg Family Medicine, and as we do the third Wednesday of each month, give a talk on a different medical topic. Today, we're going to talk about dementia and Alzheimer's disease. Just to clarify, Alzheimer's disease is just one form of dementia, and I'm going to talk about probably 2 or 3 other types of dementia that are more familiar, but there are several different types of dementia out there. We just always associate it with the Alzheimer's because that's the most prominent one. But it's important to talk about because dementia and Alzheimer's disease is actually the 5th leading cause of death in people 65 and older. And as we become older, the prevalence or the frequency of people potentially getting dementia increases. So by the time you become the age of 90, there's close to a 40% chance of getting Alzheimer's. Yes.
Did you mean to say that dementia itself could kill somebody?
There is a potential, and I'll get into that.
Okay.
As to the reasons why.
Okay.
Well, let's go there. Simply because dementia, as it progresses, becomes a debilitating disease. And basically it affects 3 areas of our brain. It affects language, it affects memory, and it affects decision-making. So all of us, I'm sure, at some point in time in our lives have crossed somebody, either family member-wise, friend-wise, or otherwise, that's had dementia.
But it doesn't affect breathing or your heart pumping.
No.
It doesn't actually kill you that way. Not
directly. No. However, the debilitation of your inability to care for yourself and your body's ultimate decline as a result of those things leads to the death.
When my father had Alzheimer's, he couldn't swallow anymore.
Right.
And they said that your systems forget.
Right. So that's one of the reasons, that's one of the contributing factors related to dementia.
But that has to do with memory too. Exactly.
Okay. That leads to death. So, and there's different risk factors out there. There's age, as I just mentioned, family history. Certainly if you've had somebody in your family that's had problems related to dementia or Alzheimer's, there's a greater chance. That kind of goes into genetics as well. But there's also some other things like anemia, hypothyroid, if you have thyroid related issues. Certainly people with vitamin deficiencies like B12, in some cases vitamin D. There's certain types of dementia, not necessarily Alzheimer's disease, but there's certain types of dementia that are vitamin deficient causes of dementia. Diabetes, liver disease, kidney disease. So again, is it the dementia itself that kills you or leads to death? No, but it's the other things related to your body system that can cause that. And another big thing here is head injuries. So people that have had major falls, what we call traumatic brain injuries, people that played a lot of contact sports, boxing, football, soccer, are individuals that are higher risk because of head injuries that can lead to dementia. What's that?
Or even a car crash?
Absolutely. Significant multiple, what we call motor vehicle accidents or MVAs, depending on, I've even seen head injuries related to, on a couple of occasions when I worked in the emergency room, the airbag deployment. If you're not prepared for that, can cause a significant, while the airbag is supposed to protect you, in reality, in some unfortunate cases, it can lead to injury. But if you want to scroll a little bit. So we all know, we've all had occasions where we walked into a room and said, now what the heck did I come in here for? Or where did I leave my car keys? We're all guilty of that. The question becomes, is that an isolated incident or is it becoming a pattern? Are you going somewhere and all of a sudden you don't remember how to get home or something like that? these are the types of things that cause concern. So, as it indicated here, some of the symptoms are, forgetfulness, like I mentioned, but difficulty performing tasks. Now, there's two types of tasks. There's what we call ADLs, or activities of daily living. Those are things that we do for ourselves, like bathing, grooming, toileting, being able to feed ourselves. And then we have what we call IADLs, which are independent activities of daily living. Those are the things that include what we call executive functioning, like being able to add numbers, being able to balance a checkbook, being able to pay your bills, things like that. I talked about being confused or disoriented, troubles with communication and speech. Like I said, one of the areas of the brain that affects is language. Some of the dementias that I'm going to talk about are more related to communication than others. Obviously, troubles concentrating and reasoning, but where we start to get into some challenges is as dementia advances, it affects other parts of our well-being. And certainly we know one of those things being appetite. You're not going to eat as much. You're not going to be able to eat as well. You're just not as interested in wanting to eat. So what happens? We start to lose significant weight. And then there's the question of later, as dementia advances, do we need to consider alternate modes of nutrition? Typically toward the end of life, people stop eating, and then some family members will say, well, should we be putting in a feeding tube? Having sat on a medical ethics committee, well, I still sit on a medical ethics committee, we get that faced time to time, but studies have shown that trying to put a feeding tube in an individual just for purposes of nutrition later in life as their dementia advances does not prove beneficial and does not improve quality of life. If anything, it only delays the dying process, and that person might be suffering a little bit more in the process because some of those individuals may not even be able to tolerate the tube feeds. But as we get into all this, we need to start thinking about, wow, is this again, an isolated incident, or is this a concern? And what do we do about that concern? The first thing you do is hopefully get to your primary, admit to yourself that there's a problem, or listen to family members who might be saying, Mom, Dad, I think that there's something going on here. And that person giving in or admitting, saying, yeah, I kind of feel like there might be something too. Let's go to the primary care physician and check this out. Because the very first thing that the primary care physician has to do is determine whether there's clinical suspicion. Is this truly something that is a quick fix? People that have had urinary tract infections, people that have had other type of infections, particularly as you get older, they have confusion. So if we fix that UTI or fix the virus that they have, we'll be able to clear this up. Or is this something more serious? So there's going to start to do some testing. The very first thing they'll do is just simple verbal testing. There are different types of tools out there that the primary care physicians can use. One of them is called an MMSE, a mini mental status exam. Another one is Montreal Cognitive Assessment. So there's different ones out there they can use, but some of the things they will say is count backwards in threes from 100. So, some of us might say, wow, let me think about that a second. Okay, I'm ready. 97, 94, 91. Don't make me go beyond that because I might screw up. But, or they may say to you, I'm going to mention 3 words to you. World, ball, and pen. And then they're going to chat with you for a little while. And then they're going to say, do you remember the 3 words that I asked you to recall? Some people are able to accurately do that, some might remember one or two, but that kind of works into the process. The third thing they're gonna do is maybe have you draw a clock, put the numbers on the clock, and write, 1 through 12. And then they'll say, okay, with the hands, big hand, little hand, show me what 11:10, it doesn't matter AM or PM, what 11:10, draw 11:10 on that clock. So they're looking at, do you remember how to do that? And also visual spatialization. So sometimes if you look up at the clock on the wall, it's all evenly distributed, but sometimes you see people with putting all 12 numbers on one half of the clock, or all toward the top half of the clock, or they don't know how to properly put the hands on the clock. So these are things that just help them determine. Those are the easiest things to do. The next thing they're going to do is screen for depression, because sometimes depression mimics dementia. When we get to the point of depression going on in our lives and it is untreated for so long, it can start to do a lot of those things, like I mentioned, changes in appetite, sleeping more, just not wanting to be around people. And that's the other thing with people with dementia. They're going to try and cover it up for as long as possible. They're either going to try and isolate themselves, or if they're having a conversation, they're going to start to say, oh, you know what I'm talking about, just so that they don't have to finish those sentences. Then when we move from there, they're going to do lab work. Like I said, I mentioned earlier, there's things like anemia, hypothyroid, vitamin deficiency. They're going to take a look at all that. One of the very last things they would do is do a CT scan. Do we need to do a CT of the brain or an MRI of the brain? Those are very costly procedures, but they might prove helpful at a later point in time, particularly with different types of dementia and seeing if you have a brain bleed.
Oh, we missed several.
I'm just going to scroll back down here. So as dementia does get advanced, probably one of the biggest things that two of the biggest things we see is behavior. I don't know how many of you have been exposed to individuals with advanced dementia, and I'm talking Alzheimer's disease. I'm not necessarily talking about the others, but you're going to see changes in their behavior and personality. They get a little bit more far more defensive, aggressive. Their personality changes, and you're like, whoa, this is not the person that I knew Tony to be, even a few years ago. They're going to start to hallucinate a lot more. I see this very frequently. The last couple of 3 individuals that I knew before they died had a lot of hallucinations. Certainly, they're unable to take care of themselves. And then finally, unfortunately, they have bladder and bowel issues that they just don't have the ability to control.
And the hallucinations wouldn't necessarily have to be visual, they could be auditory.
Absolutely. Okay, so I'm going to have you scroll because we're going to talk about some of the different types of dementia. The first one, like I said, is Alzheimer's, just because this is the most common. And this is where brain cells die over time. So we have these proteins that build up, and I'm not going to get very specific, but what happens is sometimes, like when we have proteins build up and plaques build up in our arteries and our veins, the blood flow isn't able to get properly to our heart. Thus we have heart attacks and we have strokes and things like that. The same holds true with dementia. These plaques build up, they're called taus. But when they build up in your brain, they don't allow communication from one part of your brain, all these little synapses, to communicate across these little gaps to others. So when that happens, these brain cells die over time. The other thing about Alzheimer's is it is a very, very slow disease process. So the average length of time, and again, this is the average individual from the time they are diagnosed to the time that they, to the time that they die is typically about 4.5 years. Some people it's far shorter because that disease process is a little bit more quick for them. And some of these people unfortunately live for several years with dementia. But you can see it. And we're going to talk about treatment and medications and stuff like that here in a little bit. The other one is vascular dementia. This is probably the next one, where I said blood doesn't necessarily, the brain doesn't get enough blood, and things are blocked. But like I said on the bottom there, this form of dementia is the most common about people who have strokes. So this is vascular dementia is more related to strokes. The next one would be dementia with Lewy bodies. I don't know. Lewy body dementia is kind of interesting because this is where these protein deposits in the nerve cells interrupt the messages, but also this is the one that you experience the most visual hallucinations, the most problems with sleep disturbances. And this is the one that, as you guys probably recognize who this is, Robin Williams, that's what he died of, was Lewy body dementia. Parkinson's disease is a movement disorder. However, people with Parkinson's, as it continues to progress, develop dementia. Most people that I've known that are have a diagnosis of Parkinson's and are 80+ years old are now more prone to getting dementia. And now you're looking at total care of that individual because they're not able to walk on their own, they're not able to take care of themselves. And we'll talk about caregivers here in a little bit. And then probably the other one that I wanted to mention that is not on here, but it's called frontal temporal dementia. So this is where different parts of the brain develop a lack of blood flow. And this is the one, frontal temporal dementia is one that affects more language than anything. So you can see some affect, some can affect communication, some have the hallucinations, some have the sleep disturbances. That one affects language. And then there's a few others, but again, those are the ones that are higher in percentage. So Alzheimer's dementia is obviously the biggest one, and then the percentages go down with the others. If you can scroll down here a little bit, we talked about some of the tests. And then, there we go. So in terms of treatment, unfortunately, there's not much out there. There have been hundreds of medications that have been in the pipeline for many years, but there's no proven ways to prevent it. Or if somebody's been diagnosed, what the focus is on is trying to slow it down. Right now, I would say on the market, there's about 2 or 3 medications that help to slow the progression of dementia. However, you have to determine there's basically mild, moderate, and end-stage dementia. One of those medications helps to treat it in the mild to moderate stage. One of them helps to treat it in the moderate to severe stage. There are a couple of other medications out there that were about to be released in 2024. However, the the Food and Drug Administration has them on hold right now because they're double checking the safety of them before they roll them out. A year or 2 ago, they released a new medication and everybody gets excited, but they learned that it was only helping a very small percentage of people and it wasn't significant. And what's the other problem associated with these medications? The cost. Number one, the side effects. Number 2, the cost. Because these these drug companies put in millions and millions and millions of dollars into these medications, they're gonna want their money back. And some of the insurance companies aren't gonna wanna pay that. Some patients and some families are desperate and they're willing to pay that $500 a month or $2,000 a month. I've even seen $3,000 a month, and there really hasn't been much benefit. The other thing about these drugs, I should say these medications, is it takes 10 years from the time that it's created to the time that it gets approved to go to the market, because they have to go through so many trials. Yes.
So the difference in these drugs isn't that one more treats Parkinson's and one that more treats Lewy body, and
No.
one, they're just beginning stage,
Right.
middle stage,
So-
and end stage.
So Parkinson's by itself as a diagnosis has its own medications. What you're treating in terms of these medications are some of the symptoms. Trying to slow down the memory loss, trying to slow down their hallucinations, trying to slow down, the language barriers. Yes.
Yesterday I got from AARP their newsletter. They had a long article on what's being done now for Alzheimer's. And one of the ones that has been approved works for 5 months.
Right.
And that didn't
Right.
make it, but it looks like there's a lot of things in the works, but.
There are a lot
not
of things in the works. Like I said, there's been hundreds of drugs, but they have to go through all these trials, and those trials basically last about 10 years. So like I said, what they're trying to do is basically treat the symptom, because you can't reverse the process. The focus has been on trying to reduce the process. One of the biggest things for me is making sure that we're caring for the caregivers, kind of looking out for those individuals who are having to be with that person on a daily basis, and how tough that is. Making sure that, once they wake up in the morning, getting them out of bed, getting them dressed, getting them fed, making sure they don't fall, keeping them safe, bathing them and everything. Some people try and do that on their own. Some, get an aide to come in. One thing that I'm very thankful for is in our communities, there is two things. There's an Alzheimer's Association, and I just read last week where this building is getting the memory lane.
Yep.
So that is for individuals who are looking for like adult daycare, like respite during the day. So it gives family a chance to go run errands or work a part-time job or give the caregivers a little break, so having read that last week made me feel
Yeah,
good.
we also have a program on the first and third Fridays here called Guiding Pathways. That's a respite program.
Right.
For caregivers as well.
And support groups for caregivers. Hey, tell me what works for you, because I'm a little frustrated right now. So those types of things help. But the other thing is, again, reaching out for help, getting those resources, taking care of yourself, and financially and legally planning, making sure we have advanced directives in order, making sure that if this person had, bank account or owned a house and that, somebody to kind of take care of those things for them. And I mentioned a little bit about the resources. But I'm gonna stop there just because we're close to 11:30. Any other questions, comments? Hopefully you found, this I'm gonna do real quick. And by say real quick, I have 10 ways to love your brain, but basically I'm just gonna say that there's 6 lifestyle factors that play the biggest role in our brain health. Physical exercise, food and nutrition, so eating properly, medical health, making sure you're seeing your primary care physician, following through, taking your medicines, sleeping properly, trying to stay away from, stop smoking, cutting down on alcohol, your mental fitness and social interaction. So being at places like here at this facility, at the Wood County Area Office on Aging, and being involved in programs like this, or being out there where they're doing puzzles, or even just being with others and having lunch together. Believe it or not, those little things make a big difference in life, particularly later in life. So Thank you for flipping to that, because I forgot I had that last page. I'll stick around for a couple of minutes in case you have any personal questions, but thank you for your time. Wish you a good month, and we'll see you soon.